afternoon. Welcome to the webinar, Strengthening Services for Youth by Using Evidence-Based Programs and Partnership. I'm Jessie Watrous, and I'm the Evidence-Based Practice Director at the Institute for Innovation and Implementation, University of Maryland School of Social Work. And today's webinar is the last in a series, and we hope you will check out that series. We've been able to cover a wide range of topics related to supporting evidence-based programs in partnership with systems. I'm pleased today to be able to introduce you to my co-presenters, Deborah Harberger and Suzanne Fields. Deborah?
Good afternoon. I'm Deborah Harberger, and I'm on the faculty here at the University of Maryland School of Social Work at the Institute for Innovation and Implementation. And I direct our Ruth Young Center for Maryland at the Institute, and I'm director of our Policy, Finance, and Systems Design Division. So I have the opportunity to work deeply in Maryland as well as with other states on child welfare, behavioral health, Medicaid reforms. And I'm joined by my colleague, Suzanne Fields.
Hello, everyone. I'm Suzanne Fields, and I am Senior Advisor for Healthcare Finance and Policy, also at the Institute. And my area is supporting states to design and implement children's behavioral health systems in Medicaid and child welfare, including experience implementing and supporting evidence-based practice in Medicaid and child welfare programs. So very happy to be here today with you all. And we wanted to begin today with a poll, beginning to understand a bit about people's comfort with this topic. So our poll question was, how comfortable are you with discussing public financing of child and family services? Are any of you terrified and can't believe you're spending time on this topic? Are you somewhat confused but starting to understand more? Are you fairly comfortable but not necessarily an expert? Are you definitely comfortable and learning more every day? Or are you completely comfortable? You do this as part of your work. So if attendees could go ahead and take a minute to respond, and if we could go ahead and close the poll. And it seems that we have folks who are both running the gamut, unsure about what to expect, and not certain what they're weighing into, all the way through getting somewhat comfortable with the topic area. So very happy to have you with us today. So thank you. We can go ahead and close out that poll, please. One of the areas or the challenges in the implementation and sustainability of EBPs is they're often hampered by the fragmented funding that's available to support and sustain children's services. Various funding sources are used, and despite a lot of clarity around the effectiveness of EBPs, they're very limited uptake. The implementation required to implement EBPs requires a lot of additional services and supports in addition to that direct service to children and families. Those things include data collection, quality improvement activities, training and coaching of staff, constant recruitment and retention activities, given the high turnover rates that can occur in this field. And so all of those different pieces tend to create challenges for providers and systems to sustain really effective evidence-based practices. If we could move to the next slide. And what we see when we have these evidence-based practices is that there are a variety of different funding sources that are available to support these evidence-based practices, but they tend to be disconnected from each other. And bringing those together does tend to be at that provider level, where the provider is left to try to coordinate that funding, to bring it all together and to make it happen. And that's very time-intensive work. at the provider level. And what it means is not all children and families have access to evidence-based practices. And it also means that as funding streams or demands change, providers are left holding the bag, trying to figure out how do we sustain this and keep this moving forward. If we could move to the next slide. So what can we do about that and that current reality that we have? And that is really kind of looking at how at a system level can these various funding streams be brought together to support the use of these evidence-based practices. And that requires kind of a strategic direction on behalf of all those various funding streams. If we could move to the next slide. And so as we think about strategic direction, and as we think about how to ensure alignment, what we often begin to consider in terms of these evidence-based practices is kind of what do we need to do, kind of that acceptability piece. What can we really have available in our system that can work? That appropriateness piece, which is really about who are we trying to serve? Who's that shared population? And how can we think through across our system about what could support those children, youth, and young adults in that kind of shared population way? And then finally, this notion about what's feasible, what's really realistic that we can pull off within our resources, within the structures that we have in our particular jurisdiction or state. And it's at that center of all three of those aspects of selecting EBPs and considering what could work is where we need to begin to consider the payment strategies and the payment opportunities that are available for EBPs. If we could move to the next slide, please. So one of the pieces that we're talking about today are the funding streams. So how to leverage Medicaid, how to leverage child welfare dollars. There are other aspects to financing which tend to be more about the mechanisms to use those funding streams that we're not necessarily going into in detail today. So those mechanisms, I mean, are like pay for performance or case rates. And those types of strategies can be used with a variety of different funding streams. So today we're very focused on the funding streams, either using them individually or of course strategically bringing them together out of recognition that not all pieces of what each funding stream can do can support every EBP in its entirety. And so as we think about what's needed to fund EBPs successfully, there are a variety of different things. First, it has to do with that initial startup. There's costs associated with being able to start use of an EBP. Those can be both within a provider, such as training, recruitment of staff, their own agency infrastructure. It can be about preparation of direct service, other aspects related to the data collection, understanding quality measures, understanding what information they have to collect, and most importantly, from an improvement perspective, the infrastructure needed to be able to use that quality data to improve the performance on an EBP. And inherent in that is documentation. That's one area that we see in EBPs in terms of funding. That's one particular area around documentation and the amount of information that can accompany some use of EBPs that often goes unfunded, that is really necessary to support from a rate perspective or a reimbursement perspective. Of course, finally is training and coaching. We know from evidence that it is more than just training that needs to happen to really support use of evidence-based practice. It is that ongoing coaching and that opportunity to improve the application of one's use of an EBP that leads to the effectiveness of those EBP models. And it's very important to be thinking not only about that initial training and what gets designed, but that ongoing coaching. And that can include ongoing coaching. It can include kind of advancement for staff to be able to become supervisory supports within these EBPs as well. Next slide.
Great. So there's some financing terms that we may use, and so we want to make sure that there's a shared understanding. At the end of the slide deck, there are definitions of some of these terms, and they will be made available to folks, some additional ones that aren't included on this slide as well. We talk a lot about blending or braiding funding, and that's important to know when you're looking at other states for examples. That really speaks to this intentional coordination of multiple funding streams. Blending tends to be when they all come into one big pot together. Braiding is when they still kind of hold their distinct reporting and tracking, but can be used together to pay for something. When we talk about maximizing federal reimbursement, that talks about how much money we're able to get from the federal government for a particular service based on the money that the federal government makes available depending on the program. Sometimes there's a match of a certain amount that might be 50% or 75%. And states can maximize federal reimbursement, get more money from the federal government to reimburse them for services by expanding access through including more services, expanding the population of who's eligible, expanding the providers who are eligible, and making sure that just in general, people have more access to the services that are eligible for reimbursement. There's downsides to all of that, and we'll talk about some of the pros and cons of some of this a little bit later. And then when we talk about Medicaid eligible, there are three main, to oversimplify this, there are three main pieces to being Medicaid eligible. One is the child or kind of quote recipient of the service Medicaid eligible, as in do they have Medicaid coverage? Most kids in foster care are covered by Medicaid, but then there are kids who have community coverage based on the income of their family, and then there's other ways that kids and families have access to Medicaid. There's also a question of, is the service allowed under Medicaid? Is it in the state's plan or a waiver? And we're going to talk about what that means. And then you still have the question of the provider. A service can be eligible, a child can be eligible, but if the provider is not eligible to provide that service in Medicaid in that state, then it's not Medicaid eligible. So we use that term, but it's actually fairly complex. My colleague, Melissa Schober, put together a number of these slides, so I want to give her credit. And, you know, you've seen one child welfare state, you've seen one Medicaid, you've seen one, right? It's different. But so when we talk about Medicaid financing, in general, the federal government matches state Medicaid spending based on what is spent for which services for which eligible participants. And the rate for that match ranges. Sometimes there's higher matches for particular services or for a period of time. And in general, the federal government contributes more in states that are poorer. Like a state like Maryland has a rate of 50% because Maryland is considered a less poor state based on income and resources and in the state. So changes to eligibility and services could have an impact on all of this. Medicaid is part of the Social Security Act, that same act that gives us Medicare and other things. That includes Medicaid. Title 19, it's only been around since 1965. And this is just a brief description. But one thing to remember is it is the single largest payer for mental health services in the US, and increasingly a bigger role for Medicaid in paying for substance use disorder services and treatment. And like I said previously, almost all kids in foster care are Medicaid eligible. One piece of Medicaid that is important to think about is what's called EPSDT, Early and Periodic Screening, Diagnostic, and Treatment Benefit, which gives access to preventative health services and treatment for kids under 21 in Medicaid. So that's a really, really important way that kids and families access services and treatment across the country. If you're wondering what your state plan looks like and what it covers, you can look at it yourself. You can go online to Medicaid.gov, and you can search state plan. You can look for examples of other states who've done different things. But the state plan is where states put in all their amendments and all their information for what will be covered, who's covered, for how long, what are the options, what are the things that are included and not included. There's operational information, there's reporting information, there's a lot of information. Some states do a pretty good job of keeping kind of almost a running compilation of all those on their website. Other states are not as good at that, but you can always go to this website and search, and you can filter by date, by topic area, by state. There's lots of different ways to do this and see what's actually covered. And what you'll see, and I know years ago I was surprised to learn this, is that states make amendments to their Medicaid state plan all the time. It's a routine occurrence. It could be because of inflation and needing to change rates. It could be to include a new provider type. It could be a big amendment that has required a lot of stakeholder involvement. But the state plan gets opened up a lot. And I think sometimes there's this myth that nobody can touch the state plan, that it's untouchable, but actually it's opened up all the time. And you can see that if you go to this site. We talk about waivers a lot in Medicaid, and that's something that I think confuses folks, but it's this idea that the federal government gives permission for states to waive, to put aside a particular requirement. And so I love this slide that Melissa created, because it's just this idea that you have an idea, and if it's in the state plan, you can do it within the flexibility provided by existing federal rules and regulations. And if you do a waiver, which is still an authority provided by the federal government, it gives you this extra flexibility outside of the regulations. There's other rules. There's often even more reporting and renewals and things that have to happen. But it just means that there's a more flexible way that usually you can test or try out an idea, or give access to a population that might not have otherwise had access. And Suzanne, feel free to jump in and interrupt me for anything. So you also hear about states talking about carve in, carve out. And that's language that can feel like a barrier to understanding what your Medicaid plan looks like in your state or how Medicaid's accessed. But really it's talks about managed care, and most states have some form of managed care. But there are populations that can be carved into the managed care or carved out and held separate. Some states have these specific populations that they hold separate, and they treat them differently in terms of their services, their access, their benefits. And that changes over time. So this is just a little example of Maryland and how we have an 1115 waiver, like we just talked about. And we have managed care under that 1115 waiver, but our public behavioral health system is a carve out, which means we end up going through a fee-for-service system for that instead of going through managed care for the public behavioral health system. So, like I said, fee-for-service, there's lots of different ways that states deliver that care. Fee-for-service means that there's this direct transaction. The state contracts with the provider. Sometimes you have an organization like an administrative service organization, that ASO, that helps facilitate that payment and oversight and utilization management. But essentially they're directly contracting. You go, you get the service, you see the doctor bills, the doctor gets paid from the state. There's a rate and it's direct. Managed care, the state gives that money to the managed care company and pays them. And then the managed care company is managing those services, those providers, what they pay them a little bit differently. And there's pros and cons to both depending on scenarios, but that's sort of the 20,000 foot version of fee-for-service versus managed care. So like we said, looks different everywhere. This is a map from Kaiser, and it talks about Medicaid expansion and how that looks. And so every state looks a little different. So it's important to know what your state looks like, whether you're an expansion state. You need to know how your state functions before you seek any sort of change. So there's a lot of different challenges and opportunities and things to consider when looking at your Medicaid state plan and waivers and what the opportunities are. thinking about all the things Suzanne outlined before about funding for evidence-based practices and how are you going to pay for that? How are you going to sustain that? Your state might have a particular approach to rate setting, and you may have to propose something like, is it a case rate? Are you doing 15-minute billing increments? Who has oversight over this? Is it going to fall within managed care, or is it outside of managed care? What are you going to pay for in your rate? Is training and coaching part of the rate? Does the state pay for training and coaching through an external contract? What is your state budgetary environment? So if you want to go forward and propose something, on the one hand, when you put something into the Medicaid state plan, sometimes you have the benefit of this extra federal reimbursement, maximizing that federal reimbursement. However, when you put certain things into the Medicaid state plan, they're more accessible to more people, which can be a great thing, but it also has the potential to be more expensive. So even though you're drawing down the additional federal funds, often states are wary of putting things into the Medicaid state plan if they weren't a benefit before. So that's something to consider. The federal government doesn't have that balanced budget amendment, so they can spend and go into deficits. And that's why we talk about raising the debt ceiling. But most states have to maintain that budget balance, that balanced budget. And then you have to think about your providers. Do you have the workforce? What does it look like? Are you a more urban community? Are you a rural or even frontier community? Are you going to have the kind of workforce you need? Are you going to be able to pay the necessary rates? Is this a good fit? So all those questions that I know this whole EBP series has been delving into really gets to that. And then finally, the administrative burden. Those waivers we're talking about, they have the potential to be a very big administrative burden. Lots of reporting, lots of tracking, renewals, documentation, data analysis, and collection. Oversight and transparency is very important. Quality improvement is very important, but the administrative burden of some of these sometimes outpaces the benefit. So those are all things to consider. So I'm going to hand it back over to Suzanne.
Thank you, Deborah. Appreciate that. One of the pieces that we thought would be useful was to highlight a few examples from across the country about the sustainable use of evidence-based practices. One of the there was a recent study surveying all of the mental health directors from across the country. And I think the study had 44 responding about kind of their support as the behavioral health authorities specific to behavioral health evidence-based practices. And in that study, 3/4 kind of talked about one of their key strategies for sustaining use of EBPs was funding through the Behavioral Health Authority dollars, the training and coaching to accompany the EBPs. And that was in recognition of that being kind of a primary expense at startup, it being a continued expense for kind of continuity or sustaining the EBPs. And that's where they saw, as we kind of go back to one of those early graphs we showed you about all the different funding streams, that's kind of one core area that the Behavioral Health Authority said, this is clearly in our jurisdiction to support workforce and skills in an application of best practices to meet the needs of children, youth, and young adults. And so that's one of the kind of core strategies we're seeing across the country is really leveraging the Behavioral Health Authority dollars or state general revenue dollars to support either a center of excellence or some type of concerted, coordinated training and ongoing coaching effort around these types of EBPs. A second strategy that we're seeing in multiple states is building on what the states already have in their Medicaid state plan or waivers and adding to that. So as a specific example of this, and again, this is occurring in many states and is likely occurring in your own states, is taking a service that Medicaid already funds and then adding additional requirements and payment opportunities when that existing service is delivered through an evidence-based practice. So for example, in Ohio is rolling out a new effort to address the needs of children with very serious behavioral health needs. And for a long time, Ohio has had an intensive in-home therapy program where teams would go into people's homes to provide intensive therapy to support a child to remain in the community. And that's been a generalist approach. It has not necessarily used a certain evidence-based practice. So that's a service already covered in Medicaid. And what Ohio has decided to do was continue paying for that service, but add additional requirements and additional opportunities for more funding for providers who chose to pursue providing MST or FFT. So we see again as an example in Medicaid programs across the country, maybe building on what they already have in their service array, adding additional requirements, and then adding new either payment rates or incentives rates to ensure that those EBPs are being used. So that's a second example we wanted to highlight around sustaining use of EBPs. A third example we would highlight is where the managed care plans, so the partner with the Medicaid agency that's actually providing and delivering care to Medicaid enrollees, invests in the use of evidence-based practices for its particular members that it serves in its health plan. And an example in that is in Pennsylvania. There has been one particular managed care organization that's a specialty. They just focus on behavioral health, that through various mechanisms has rolled out different evidence-based practices in their provider network and accompanied it with value-based payment. So they would pay a core rate for a particular evidence-based practice that's being provided. And in this particular one, they were using both assertive community treatment. They were also funding trauma-informed approaches. And then they were also funding specialized school-based interventions. And so within those, they were using those evidence-based practices. Again, these are all serving different populations, but they had this strategy in their health plan. And what they would do is they would pay providers their base rate for providing that service. But if they met certain performance benchmarks, they could get paid more money. And so those performance benchmarks tended to fall in three different areas. The first was keeping all of the staff trained and certified, right? So if you keep all your staff trained and certified, you'll get an additional bump in money. And that was to incent the providers to invest in that training, but then they could recoup that cost. There are some challenges with that because that required providers to have some upfront money to do that. But if they did keep those their staff trained and certified, they were going to be able to get that money back. Another way that they did that within this managed care plan was if they met certain metrics. So we can see with some of these evidence-based practices that they were able to ensure, say, reductions in use of inpatient stays or emergency department use. And so providers who met those types of changes were also able to get an additional amount in pay. So that is a kind of a third example from across the country of how we see sustaining use of EBPs and trying to kind of move quality forward. The last example I'll highlight today really comes from these broader system levers, and it has to do with what Washington State has been doing. Washington State's legislature, over a period of time, really required, they took various positions and required over a period of time greater and greater investment in the use of evidence-based practices within the Washington State public behavioral health system. And this started back in 2011, 2012, and in subsequent state legislature activities, they sought to improve that by ensuring that rates were available, et cetera. So that again is just some of the examples of the various ways that states have tried to sustain the use of EBPs. If we could say one piece to kind of support the use, if there is only one thing you would take away from kind of today's discussion in today's webinar, is that funding and supporting EBP use is possible within Medicaid, and it is possible within kind of child welfare dollars. So it's very important to be able to hold on to that. There are no kind of barriers from a federal perspective in being able to do that. And some of the barriers that often get cited are actually not federal barriers. So there are ways within Medicaid to support documentation, data collection and data synthesis, non-direct face-to-face time. All of those different pieces that have been hard to fund historically in EBPs are possible to do within a Medicaid environment. And one of the kind of core recommendations that we have for folks as they begin dialogues is to think about how to bring multiple funders together in that kind of shared dialogue so that you're highlighting early what each different funding source can do. So if you're bringing together maternal and child health, child welfare, schools, Medicaid, private health insurers, this allows you to begin to see what all of the different payers, can be bringing to the table. Really be able to be clear about what an EBP impact can be and for whom it can be for. And this tends to be a kind of a focus on return on investment. If you're able to offer these types of services, these are the outcomes for youth. It's very important in these state and jurisdiction environments to be able to present near, mid, and long-term goals. A lot of the orientation towards EBP were able to demonstrate long-term outcomes. The challenge is those long-term outcomes are often benefits to other systems, but you're knocking on a payer door that may not experience that long-term benefit. And so you need to be able to think about what is the benefit for that Medicaid agency, that child welfare agency, the behavioral health authority, whatever multiple funders you're seeking of, what's that immediate benefit? What does it mean midterm? And then what does it mean long-term? You got to be able to have that view to be able to kind of align it because of state budgets, how they work, kind of their state system accountability. Also, it's important to think about how the EBP aligns with existing services. The example I use from Ohio, I think, is a helpful one because it wasn't as if MST and FFT had no starting point in that system. There was already a robust service that had many of the same elements that could be built from. So it's very helpful to know what already exists in the system and be able to articulate how EBPs enhance what already exists or can build forward what a particular system has already been funding. Oftentimes when people talk to funders, they hear a lot about what can't be done, right? Medicaid can't pay for documentation time, or Medicaid can't, pay for transportation time, or whatever the scenario might be. And so it's really important to know what is possible and isn't possible. Certainly, we've highlighted already a lot of resources for you, and I know we have some additional resources we're going to be sharing. Oftentimes, though, what is possible, you can see in your own state system. So oftentimes there are already exceptions in your own state system that you can point to and say, the medical side is doing that already over here. How come that can't apply to the behavioral health side? Or this pilot was done, How come we can't try this pilot? So those exceptions do exist in every system, every state, as states are trying to get innovative and test things. And it's important to reflect on those exceptions and figure out how it may apply to what you're trying to do around EBPs. Next slide.
Great, thanks, Suzanne. So I think that, in thinking about these EBPs, to Suzanne's point, on the one hand, you don't want to get caught up unless you are the state agency or the county agency that's running the system. You don't want to get too caught up in the precise mechanism of how you could fund it, as much as being prepared with the sense that there's a lot of different ways that you can finance things. Because what I'll say is that while resources are finite, financing strategies aren't really. There's a lot of options out there. And so don't be held back just because you're not sure which particular finance strategy would be best. Come in ready to talk about it. And so we want to make sure that you have that strong foundation. So not just on the Medicaid side, but also on the child welfare side, because there are some things that Medicaid doesn't pay for. Medicaid is heavily focused on those true clinical services. And sometimes we know kids need more and things that come around it. And so we want to spend a few minutes talking about federal child welfare funding and making sure that you have some foundational information about that as well. So this is the lightning version of child welfare financing. I'm guessing this is familiar to a lot of you. Child Trends is a great resource for information and just thinking about how funding is spent. There is a lag in reporting of data on Medicaid and child welfare sides. So these data are a little bit, this is a 2016 statistic, and they don't have an updated one, but it's about the same actually in 2018. So you see about 55% of child welfare funding is actually coming from state and local agencies. And then 45% across the country is federal. Of that federal, there's a huge mix of things, including Medicaid, but also some child welfare specific funding sources like Title IV-E and Title IV-B, but then other funding sources that aren't specific to child welfare, like the Social Services Block Grant, TANF, the Temporary Assistance for Needy Families, and other kinds of funding streams. There's a lot of variation by state. So just like Medicaid state plans look different, child welfare funding looks really different. So this is a 2018 survey that was done, and it's probably, if you're from one of these states, it's probably not perfect. It's based on a survey response, but it gives you a sense of how different states are using federal, state, and local funds. So you can see Delaware has a very small amount of its money coming from federal sources, and a much larger amount of its child welfare funding is coming from state and local. And sometimes that can be because they're doing a really good job of serving kids before they come into foster care. And other times it might be because they're not doing a great job maximizing federal reimbursement, or it could be some combination. So this is just a quick overview of Title IV-E funding. I got a question the other day from somebody who says, I just really don't know how Title IV-E funding and eligibility works. And I've never understood it. Can you explain it? So essentially, the financial eligibility relates to whether a child meets a 1996 standard of poverty and has combined assets of less than $10,000. So fewer and fewer kids every day meet that eligibility for Title IV-E on a financial side. There's also some other technical eligibility. People refer to the penetration rate of Title IV-E, which just talks about the percent of kids. So Title IV-E is important, and it's not the answer to everything because it has its limits in terms of what it'll even pay for. And it's not even available to every kid in foster care. In fact, it's available to less than 50% of kids in foster care in most states. Family First, I know if you're on this webinar, you are probably familiar with Family First and the prevention services piece of it. So I'm not going to dwell on that, but just to acknowledge that there's some tricky financing things to figure out, including the limitations on what's even an eligible prevention service, and those categories of well-supported and supported and promising, and what is, hasn't been reviewed yet, and the complexity of that. the question of how each state is defining a candidate for foster care and what that looks like, what the match looks like for all of that. States still have to maintain a level of effort, which is a great way for you to get in there and advocate for additional services to help ensure that maintenance of effort. And states still have to do all this documentation, and still Title IV-E in most instances is still the payer of last resort, unless Medicaid decides it's the payer of last resort. That's the question that everybody has, is who is actually the payer of last resort, which means if a child's eligible for both, which one pays? More recent things we've seen seem to suggest maybe Medicaid's the payer of last resort, but there's not great federal guidance on that one. Social Service Block Grant, money comes to the state. It's not per individual child. The state figures out how to pay for it and what they have to do. It's a formula grant to the state that can be used in a lot of different ways. But this is a great way for people working in kids systems to get in there and advocate for these services to be used, particularly to fill in the needs where Title IV-E doesn't cover and where Medicaid doesn't cover. How can you use this to meet needs? TANF, Temporary Assistance to Needy Families, the program that actually replaced Aid to Families with Dependent Children in 1996. Most people think of TANF as being the source of money to pay those direct cash payments to families, and it does do a lot of that, but it also gets used for other things. And the Center for Budget and Policy Priorities has actually talked about how that percentage changes because inflation has impacted the amount that's available. And there's a link in this slide for you to go and see how your state spends its TANF funds. It's really, I think, informative to see what does it do with its funds, how does it use it. Some states use TANF for kids in foster care. So is that an option to look at? So finally, this is a chart that my colleague Catherine Baxter put together, looking at going through all the approved Family First prevention plans that have been submitted and approved by the Children's Bureau. These are the evidence-based practices that we have identified as being included in their plans. And so this is just an example to see, to show you the range of programs that have been approved in Children's Bureau plans. There are a number of states that have submitted plans that have not yet been approved. So I'd imagine over the next several months, we're going to see more. And there's a tremendous opportunity. If you look at some of these programs, some of them are going to be a lot trickier to fund with Medicaid, right? Healthy Families America, it can be tricky and complicated and take a lot of work and partnership to get some home visiting models covered. It's not undoable, but it's a little harder. Where something like child parent psychotherapy is going to be more likely to be something that is more easily part of your Medicaid system. And so how do you think about where you build sustainability in by having the financing in 4E and the financing in Medicaid and continuity of care for kids so that they can continue to get services and get access to them even when they're not involved with the child welfare system. So that's just a real high level of all kinds of information that we're really hoping gives you a strong foundation for you to look at your state and think about where there are opportunities to fund and truly sustain evidence-based practices that meet the needs of kids and families. So Jessie, do we have any questions?
Yes, there is one question. So there was a question that came in. How do I get my state child welfare and Medicaid agency to the same table to discuss EBP opportunities?
Yeah, it's a good question. So we've definitely seen that in a lot of states. The first question a lot of Medicaid agencies say, well, if we're going to come to the table, are you prepared to talk about how you're going to provide some of the match money for these services? So I would say one of the tricks is to make sure your child welfare agency is prepared to say, this is what we need, this is who we need it for, and here's the overlap between our population and the Medicaid population, or these kids are already covered. From Medicaid's perspective, that's also a lens that I use, which is this is already the population you cover. it's important that you're meeting their needs. And so making sure they get access, Medicaid is a great way to do that. So usually it's preliminary and we start small. Like Suzanne talked about, what already maybe exists, has been piloted, they've used state-only funds, grant dollars, what does that look like? And that's usually a point of convening. Suzanne, what do you think?
I think you hit it right on the head, Deborah, with that. There is that shared opportunity around that population that is in child welfare and is covered by Medicaid, right? And so I think it's very important to start there and to recognize that Medicaid agency will be seeking a partner around the match is really key. And so that's why I think we always emphasize know what Medicaid is already paying for, because they may not realize that what you're asking for can build upon something that's already there with some minor tweaks or some additions of who can be in the provider network.
Yeah. Any other questions? Or Jesse, anything you want to add to that?
No, okay. We have a, I don't know if folks want to, feel free to also come off mute if you'd like.
I'm going to put in the chat a resource that we put out with support from Annie Casey about partnering with Medicaid to advance and support the goals and needs of kids in child welfare.
Great idea. That's a good question. Any tips for states that have localized control over child welfare operations? Yeah. So that's kind of like a county government kind of situation in which those counties have that. Understood. Well, I'll start out and then Deborah, please jump in. Oftentimes in systems that are driven at that county level, those resources are kind of all controlled at that county level. So in some ways, you're able to kind of start smaller with let's test this concept in our county. Oftentimes in kind of county driven systems, you're more often at the same table rubbing elbows with the same people throughout the day, often back to back, right? Moving from meeting to meeting, but with the same kind of group of folks. So, we have found that actually in counties, there's lots of opportunities because you're talking at a smaller scale of a shared population. You're talking about a deep knowledge of localized resources and localized strengths and challenges. And so we've seen that that kind of county or more localized structure is able to more readily agree on here's a need we have, here are some of the different ways we can do it, and then kind of figure out how to cobble it together. In those instances where county child welfare may not be paired kind of with county Medicaid, then I think you're needing to kind of reach back up through your state child welfare agency to engage your state Medicaid authority in those kind of dialogues about how to kind of blend or braid or support funding at that level. But that I think, county governments can have Medicaid dollars at the local level as well, or there can be a split where just child welfare is localized, but Medicaid is at that kind of coordinated or one single state level. Deborah, I don't know what you would add to that.
Totally agree. I think if everyone's at the county level, it's a lot easier. If you have a split, it's a lot harder. And I think that one of the great innovators,
but still
totally doable. One of the great innovators in systems of care world in all of this is Wraparound Milwaukee. And that's where everything sat at the county level. They were able to do such tremendous innovation and sustainable innovation because it was county, it was all the county level. And so, or you can see a lot of great sustained innovation in a state like New Jersey, where it's all at the state level. And so I think you definitely have to have those relationships if it's a mix and help people understand where the authority sits. And what's allowed and what's not allowed. There are times when you can do things in Medicaid that are not for the whole state, depending on what you're rolling out, how you're rolling it out. and different things too. So there's opportunity, and it shouldn't be the reason it doesn't get done, but it does take a different level of complexity.
I'm just reminded as I was reflecting on this question about a county and a state that really wanted to be able to implement a kind of a specific evidence-based practice. And the EBP isn't as relevant here to the point, which is that they decided to use their local dollars to do a pilot and to demonstrate its effectiveness, collecting data on how it was effective for Medicaid. Then they took that pilot and that data to Medicaid and said, if this were scaled, here's the impact it could have. Or if you supported it in our county, here's the impact it could have. So I'm just kind of reminded of that strategy, that sometimes in systems where there is that kind of bifurcation with certain county dollars and certain state dollars, you may need to rely upon a pilot or a demonstration, take information there and say, look what could be accomplished if you joined us.
Yeah, sort of the pay for success initiatives that we were seeing, that I think there's still some around the country where people take, whether it's local dollars, private philanthropies. Sometimes philanthropic organizations are willing to get involved for a period of a couple of years, but they're not willing to do it ongoingly. And so sometimes that's the opportunity, is to get them to the table and see if you can get some seed money for something with a commitment from your state agencies that if it shows the outcomes you expect it's going to show, that they'll pick it up after that. So don't let financing be the barrier. And we're happy to respond to any other questions via email, reach out to us afterwards. And thank you so much for having us. I'll hand it back to Jessie.
Yeah, I just want to say thank you to all of you for joining today. And thank you very much for my colleagues here at the Institute, Deborah Harburger, Suzanne Fields. And this will actually conclude our webinar series for the year. And that webinar series has been hosted by the Kemp Center, Judge Baker Children's Center at Harvard, and University of Maryland School of Social Work. We hope that you will go to the Institute's website. I'm just posting this here, and check out that series. All the recordings will be made available. Thank you so much and have a good day.